Hello, my dear colleagues and friends. My name is Dr. Subramanya. I am Professor of Pediatrics at Vaidehi Institute of Medical Sciences, Bangalore. My area of interest is pediatric pulmonology. I thought I will share some of my views on aerosol therapy and inhalation therapy in asthma. The reason why I choose this topic is because often we found in practice that we tell many patients, convince them, counsel them, in spite of it they don't pursue the treatment properly and they will keep shopping from doctors to doctor, and finally they settle somewhere and ultimately give up the entire treatment for asthma. The major challenge today is about compliance of asthma medications and treatment with proper knowledge of technique rather than the diagnosis and its confusions. Can I take you in the next couple of minutes as to how exactly we can approach this problem and make it easier for our professional colleagues, for our friends, as well as the parents of those children suffering from asthma. What I usually do in my practice is, I will convince them about diagnosis of asthma, which is the first step. Later, I will counsel them and will have enough time to explain the advantages of inhalation therapy. You know, most of the mothers and parents, they are used to oral therapy because of wide prescriptional practices by the practitioners and doctors. So I need to counsel them and explain them that inhalation therapy is direct. For example, it's like an ointment for a skin problem, or would be like an eye drops. So these are some simple words which you can use and counsel them that the drug required would directly reach the lungs where it is supposed to act, and therefore it is required in small doses. You don't need a large dose of the drug, and because it is direct and small, it's also rapid in action and will have minimal adverse effects because the dose is also small. And I think we have the best bargain as far as inhalation therapy is considered compared to an oral therapy. More often than when I start these words on inhalation therapy, I would realize that the mothers would come back to me and ask a hell lot of questions on inhalation therapy. And I think as friends, you would also realize that many of your patients must have also been asking you, isn't it? So there will be questions, sir, is it strong? So tell them that this is small micrograms, not milligrams that would be required. Many of them would feel that this is, sir, is it addictive? Once I start using an inhaler, do I have to use it forever? You must tell them that the therapy is not addictive, the drugs are not addictive. In fact, the asthma may be persistent and therefore you may need the medications for long. And I would always counsel the mothers by telling them that the drugs don't cause dependence and the drugs follows asthma, and it is not that the asthma follows the drugs. There may be small subset of patients in many areas of practice where they may consider inhalation therapy as very expensive and not affordable, but you need to tell them that only first time you need a bit of investment on a few rupees on a spacer and an inhaler. But once the disease comes under control, most of the times the entire cost of medications, cost of therapy, morbidities, visit to the doctors, all these things are reduced and the patients are the beneficiaries. And the question often is asked, sir, my grandmother uses it, my mama uses it. Do you think for such a small child you would prescribe an inhaler? Please counsel and tell them that it can be given at any age. Age is not a problem. The disease in question has to be solved. I think I have taken you through the right steps of counseling them, and there could be many more questions, and you are all the experts in the field, that you would clear them as and when they would rise and the mothers would be counseled and convinced. The next step would be to start, I have to select an appropriate device. There are many devices available, and more often than not, the representatives in the market, the parents, patients, your colleagues, the conferences and CMEs that you attend, updating of knowledge that you would do every day, day to day in your social media or in your Google, wherever you go, or the books that you take, there will be a whole spectrum of devices that are available. Instead of looking into which device is available, can I ask you a question? Which laptop is good? Which soap is good? Use any laptop, but use a laptop. Use any soap, but use a soap. Similarly, use a device, but use the device properly and know the device properly. This is the most important crux of the matter, and the selection often depends on the experience of the doctor and the way he is counseling the parents, and involve the parents as well as the child. For example, you have an adolescent child, or you may have a very young child where a parents would take the decision, and if an adolescent girl is there or a boy is there, he would take the call as to which device he wants, and you have to give the child friendly device that is appropriate. Usually we go by the age, the drug that I want to use. Do I have to use a controller, or do I have to use it in acute episodes also? And the deposition of the drug, where I have to get it done. There are a couple of differences between the choices that we have got. Most of the choices fall into three major groups. One, I would say, is the most popular nebulizer, and I have taken it first because that's the one which you have to discourage in use in day-to-day practice. In mild to moderate exacerbations, as well as the long-term medications of asthma, nebulizer should not be recommended. And parents always feel that when they come to your clinic, you offer them the nebulizer, and they feel that that is the best device. It's actually a myth. We need to convince ourselves as well as convince the mothers, telling that the nebulizer is a poor drug delivery system. It is power dependent, needs maintenance, you need an oxygen source, but of course you need more drugs, because hardly 1 to 5% of the drug is delivered through a nebulizer into the child. In fact, maintaining a nebulizer at home, just using it whenever they want, is often a common practice that all of us have experienced, and parents often resort to using only reliever. They will never use a controller or steroids, which are basic and cornerstone in the management of asthma. Therefore, I would prefer to use the other two options, MDI with spacer or a dry powder inhaler. Younger the child, I would prefer an MDI with spacer. If it would be an adolescent or an older child, more than 6 or 7 year old, then I would prefer a dry powder inhaler. Even if I were to make a general statement cutting across all ages, in all cases, in all scenarios, the most versatile device is MDI with spacer. When I say MDI, I mean PMDI, pressurized meter dose inhaler. This would give a drug delivery of more than 15 to 20% in the airways when it is actuated, and dry powder would give just around 5% less than MDI, around 5 to 10%. The oropharyngeal deposition is very less when MDI is used with a spacer, and dry powder inhaler will have more for oropharyngeal deposition, but a small advantage would be that the patient is active and would actively participate in the inhalation therapy when he is using DPI. A small word of caution that the DPI should not be used in severe attacks. However, if that is the only inhalation available, he may just resort to as a rescue therapy, but immediately he should seek the medical advice as early as possible. Whereas in MDI with spacer can often be used in cases of flare-ups at home, initially to start a treatment. We need to have spacers. What do you mean by spacers? And I am going to show a couple of them for you. Spacers actually help us in preventing local side effects. They improve the drug delivery. In fact, when you use directly an inhaler, it would produce a kind of taste, and that is avoided, and a cold freon effect is also avoided. And there is no need of hand to breath coordination that is required if you use MDI alone, and nowadays nobody is using MDI alone. Everybody, including adults, they are using MDI with spacers. You have various types of spacers available. I am going to take you through them. You can use a small volume, large volume, valved, non-valved, polyamide, polycarbonate. You can use a homemade mineral water bottle which can be made into a spacer, and it's all available for you, but use a spacer. Do you have to use a mask if the children are below 3 years? If with spacer alone, if they can't inhale properly, then you need a mask to make an active device into a passive one and therefore inhale. Therefore, below 3 years, I am going to use MDI, spacer plus mask. Above 3 years, I am going to use MDI and a spacer. Above 6 or 7 years, I would still use MDI and spacer, but as alternative, I can use a dry powder inhaler as an option. Now I'm almost done with selection of right device. Now I am going to show you how to use pressurized meter dose inhaler and a spacer. Please concentrate on all the steps and every minute points that I am going to demonstrate it for you, because often in practice we think that we have explained. Parents often feel that they have understood. More often than not, I would always see that they come back and do many steps that are wrong. First of all, I am going to demonstrate to you and would also explain to you how to check all these things. I will explain to you the parts of pressurized meter dose inhaler. This is pressurized meter dose inhaler. It has got a canister. It can be opened and it's always full. How to know this canister is full? There were some steps that were done, like dipping in the water, seeing like this. All these things are not recommended and should not be used. Best is to document and record as and when the actuations are done, or many of the currently available pressurized meter dose inhalers have counters that are available, and you can easily see the number of actuations that have been done. What does this contains? This actually contains basically the drug. The drug could be a reliever like salbutamol, or it could be a controller like budesonide, for example. The second component is a propellant, and propellant is required because the propellant has to launch the drug into the airways, and to mix a propellant with a drug you need a surfactant. So it contains a propellant, surfactant and a drug. 90% more or more of the canister contains a propellant, and around 5 to 10% is the drug and the surfactant. Actually, this is in a liquid form, and as it is released into the MDI, it breaks into aerosols, and therefore you need to shake. When you shake, the propellant and the drug mixes and minces well and is ready for the actuation. I will show you how to do this. You need to shake at least 3 or 4 times and make sure that the propellant and the drug are well mixed. Are you all ready with me now? So you need to understand that there is a small nozzle through which the pressurized liquid aerosol breaks into aerosol and comes out through the nozzle with a high velocity, and this is exactly what happens when it is pressed, and the pressing has to be done properly, and multiple pressings should not be done, because that is not going to help us. Between two actuations you need to shake again preferably, and you need to understand that pressing multiple times would be one of the wrong steps in inhalation therapy. Now let me explain to you what happens after you do the actuation and pressing this canister. The aerosols come out. These aerosols are going to traverse through very rapid speed, as much as 100 kilometers per hour. They have to decelerate. When these aerosol particles decelerate, they are going to break into smaller and smaller particles. We need to make uniformly spread mist, and that should be subsequently inhaled. Suppose if I take this directly into my airways, the larger particles would be sprayed into the pharynx or throat, and none of them would reach the lungs. Where is the disease? Disease in medium and small airways. None of the particles would reach into the smaller space. So by law of physics, you will understand that as the particles come out of this and break into smaller and smaller, you need a space, basically a spacer, which would accommodate the aerosols that have been splayed into and would transfer it conveniently into the airways. The spacer works by following mechanism. It provides the space, it gives the distance, it allows the particles to decelerate, it allows the particles to break and break uniformly to have a common, perfectly sized diameter aerosols between 5 to 10 microns that are suitable for delivery into the distal lung. Please understand, if you have larger particles, they would be deposited in the proximal airways. If you have too small a particle, that would come back, floating and come back. Perfectly 1 to 5 micron size particles would only be deposited in the airways. Now, I have come to actually spacers now. The spacers will have two ends. One end is for the MDI, the other end is for the mouth. You may have a valve or you may not have the valve. It doesn't matter much. You can have a chamber of various shapes and sizes. That's fine. The shape doesn't matter much. Size, preferably small and large. You generally would use around 3 to 5 times the tidal volume of the child would be the perfect volume of the spacers. And that would make it very convenient for the child to actually take inhalation therapy, and too large a spacer for a very small kid would make it very inappropriate selection. However, if you have one, you can always use the one. Now, the aerosol particles which have been delivered through the MDI, that have been delivered into the spacer, can get deposited on the inner surface of the spacer. And that's why most of the spacers have got static charge, and all spacers of all the companies are actually zero static, which means that the aerosols are negatively charged and they will be repelled by the inner surface of the spacer, so that the maximum amount of the mist is not deposited and ultimately inhaled. In some of the spacers, when you are using for the first time, or you have washed a spacer and then you are using, you need to prime the spacer. Priming is done by giving around 5 to 10 actuations like this, and this would actually neutralize the inner surface, and therefore when you actually give the patient the inhalation therapy, the maximum amount of the drug would enter the airways. This is called as priming. Priming is generally recommended when you start the spacer afresh, that is at the first time in the first episode, or subsequently whenever you wash. Now, having understood this, now I am going to just recapitulate to you. I have shaken, now I have placed, you have understood the spacer, it should be minimum 13 centimeters. Now the child has to be comfortable, little chin up, and would seal the lip around the mouth end of the spacer like this. Now the next step is very important. See, after you have done this, actuated, the mist is formed inside, child has to breathe. The problem actually happens from here onwards. Up to this step, in my experience, I have found the mothers not doing any mistake. Everybody knows how to shake, everybody knows how to prime, there is absolutely no problem. Now the real problem starts. Children, whenever you give some material to them looking like this, they would look like this, and instead of trying to inhale, they try to exhale. They are very well known whistle blowers. The moment you give them, instead of inhaling, they will exhale. For example, this would be more popular than inhalation therapy. Children likes to exhale than inhale, and when they cry, they exhale than inhaling, and therefore it is very important for the child to give enough space, time, training, and make this spacer attractive with some cartoon stickers, etc., or you can put this in the play box of the child and see that the child becomes very friendly with the spacer and inhaler so that it is ready for inhalation. Now, the child takes the breath. Now, when the child takes the breath, actually we need to have a clear lamellar flow into the airways when the particles flow parallelly and would not collide with the airways and would ultimately reach medium and small airways like this. You know, you need a breathing like this. I will show you a lamellar flow and then simple inhalation that has to be done. Now the air flows in nice streamlined way into the airways. On the other hand, children tend to do this. I have seen children doing this. I will give you examples of turbulent flow. One child will do, another child. These are the ways the children behave, and I saw one child not doing anything, only shaking the shoulders. For example, they won't do anything. So this is very, very important for us to understand that the children properly inhale the mist and it reaches the airway. Now, having understood this, there is one important step which I have to tell you, that after taking the inhalation, it would be better if the child can hold the breath for 10 seconds, and that's exactly when the drug would be deposited in the airways. I will show you now. You have taken inhalation. And hold the breath. When you hold the breath only, the particles actually disseminate and get deposited in medium and small airways. And therefore, it's very, very important for us to re-explain the parents that holding of the breath is the most important step when a drug gets delivered into the lungs. Now, there are two ways in which you can achieve the inhalation techniques. One is single inhalation therapy, multiple inhalation therapy. What we mean by these two? There is a small, of course, you can use any one of them, but I will show you both of them. In single step technique, you would take in inhalation and hold and would leave. And in multiple, you would take, breathe out, take, breathe out. I will show you. So I'm not doing all the steps. In the end, I would do all the steps for you. Now, while I'm speaking to you, I'm only showing components of it. So you will take in and breathe out. When you breathe out, if there is a valve chamber, generally it will go out and it will not reach back. A child would require generally 4 or 5 breaths to empty a spacer, and all the drugs would be delivered into the lungs. And I think you have understood the inhalation techniques, and I would just show you once all the steps completely so that you would not do preferably any mistakes. Now I will show you single breath technique or a multiple breath technique. Both I would show you for convenience. Now I will show you in one flow how you can explain the mothers about inhalation therapy and technique. You would take this canister, you would check the reading, how many have been, counts has been done. You would shake properly 5 or 6 times, then you would fit it into the spacer, then you are ready. This is the mouth end, and you are going to press You can also do in a single step as well. I have just shown you one of the ways and you can comfortably explain to them the method. I have finally to tell you only 5 or 6 important things. All the steps mothers or parents may not understand in the first visit. Please give them some time. You explain them the maximum number of steps as much as you can. Even whatever I have shown you may be associated with couple of mistakes, and you know it is in a dynamic situation like this. Whenever you are demonstrating also, you can also make a couple of mistakes in demonstration, or even the parents even after having understood also make couple of mistakes. It is for you to see that the aerosol is delivered into the lungs at any cost properly and is deposited. You use a lot of common sense and redo, recheck, re-evaluate, see that every time a part of the technique is corrected. Maybe it's holding, maybe it's shaking, maybe it's pressing, maybe it is the way the child breathes out, breathe in, whether they are doing regularly or not. In every step you would see that there could be some small little corrections, and visit after visit a child would improve and would finally be able to inhale. Generally it is said that it would require 3 or 4 visits before a child would become very comfortable with the technique and learn. Please don't forget to bring the spacer as well as MDI in each visit. Let them not tell you, doctor, I have this at home, I am giving it regularly. Please see that they bring, and even if you are very busy, see that they demonstrate in front of you, so that you will be able to see many mistakes. And I have seen n number of mistakes being done. Some people don't even open the cap. The canister would be empty. They may not press well. They may press multiple number of times. They may not maintain the spacer. They may not understand. They may be giving in various wrong positions. Child may be breathing through the nose. Child may put the tongue. So many things come in practice, and each one of you will have an experience to share. I have shared only few of them. This no way for all of you means a complete demonstration of inhalation therapy, because in each attempt you would see that 1 or 2 steps needs to be corrected. With this humbleness, I will thank all of you for involving and patiently listening to join hands in inhalation therapy and aerosol therapy in management of asthma. So cheers to the parents and our colleagues for a win over asthma, and thank you very much.